This is a slide that I like starting with because it summarizes some of the important differences between cardiac allograft vasculopathy and atherosclerotic coronary artery disease, which you will probably be more familiar with. So CAV, or cardiac allograft vasculopathy, is a diffuse disease process. It affects the entire coronary tree in the transplanted heart, and it involves the length of the epicardial vessels and extends into the microvasculature. And you can see here on the lower right that pathologically it's characterized by this concentric intimal hyperplasia or thickening that's due to smooth muscle cell proliferation as well as lymphocyte and macrophage infiltration. And it causes this classic obliterative narrowing of the vessel. And this is in distinct contrast to, on the left, where we see focal eccentric plaque that is more common in atherosclerotic coronary disease, and in this case, a calcific plaque. And another important difference between these two pathologies is the speed at which disease progresses. And the group at Cedars has done some work on this and shown that if you look at percentage plaque volume increase in a transplant patient, that this is around about 3% per year as compared to 1% per year in a non-transplant patient. CAV is an important problem because it's very common. It affects 1 in 2 patients by 10 years post-transplant. And to place this into context, the average median survival after transplant is 12 to 14 years currently. It is also the leading cause of graft failure in death after transplant, and this is a figure of the major causes of mortality after transplant. And you can see that beyond a year, in red is cardiac allograft vasculopathy, and this accounts alone for 1 in 8 deaths. And also important is the green line that represents death due to graft failure, a significant proportion of which is due to cardiac allograft vasculopathy. So the pathogenesis for CAV is complex. Both immune and non-immune factors have been implicated, and this converges onto a common pathway of inflammation, coronary endothelial injury, dysfunction, intimal hyperplasia, and leads to myocardial ischemia, fibrosis, and eventual graft dysfunction. And most of this is thought to occur very early post-transplant. And we and others have used this current understanding of CAV pathogenesis to focus on diagnostic and prognostic evaluation using predominantly imaging tools, and with the aim of improving options for prevention as well as treatment for this complication post-transplant. So my objectives are that I will review some of the major challenges in imaging surveillance of CAV after heart transplantation, and then we'll review some of the emerging imaging modalities that are being used for evaluation, specifically optical coherence tomography, or OCT, invasive coronary flow assessment, and PET myocardial blood flow quantification. And I'll incorporate some of our own results. So post-transplant surveillance for CAV is critical, not only because I showed you that it was common and a leading cause of mortality, but because these patients often will have disease progression that is clinically silent, and there will be no symptoms until there is advanced disease and we have few treatment tools available. The major gaps in imaging surveillance are summarized here. Firstly, we rely heavily on the use of invasive coronary investigations, and these carry measurable risks and especially not practical when needed to be performed frequently. And most of our patients will undergo some sort of a screening test for CAV annually. We have difficulty detecting early disease. So when there are early changes just in the arterial wall and the lumen is still preserved, there's no obstruction, there's no flow-limiting disease, it's more difficult to detect this condition at this stage. We have limited ability to detect diffuse disease non-invasively, and because this is a diffuse disease process, we would expect that there might be homogeneous abnormalities, and most of the non-invasive imaging techniques rely on the presence of regional abnormalities in either perfusion or contractility to detect disease. As for any condition that affects the microvascular compartment, this is difficult to assess using conventional imaging tools. We have an anatomical gold standard for the definition of CAV, which I'll show you on the next slide, but many of our imaging tools are evaluating function. And of course, we use angiography as the reference standard when testing new tools for diagnosing CAV, and angiography itself is an insensitive tool for diagnosing CAV. So as alluded to, invasive coronary angiography is considered the gold standard for diagnosing CAV. And this is the classification system that is recommended by the International Society of Heart and Lung Transplantation, or the ISHLT. And you can see that it's a combination of the number of vessels involved, the severity of the stenosis, and whether or not there's evidence of graft dysfunction on either imaging or hemodynamics. And patients are then classified from 0, 1, 2, 3, which corresponds to no significant angiographic disease, mild, moderate, or severe disease. And this classification system is prognostic and has been prospectively shown in contemporary cohorts to provide prognostic information. But it is relatively insensitive for truly assessing the burden of CAV. And this is an example of one of our ECAV study patients. You can see the still picture on the right, the coronary angiogram showing the left anterior descending, which is nice and smooth, does not look like there's any disease in that vessel. But when imaged intracoronary using OCT, optical coherence tomography, you can see that there is clear marked concentric intimal hyperplasia that is classic for CAV and that has already occurred in the presence of a normal angiogram. So just talking a little bit more about OCT, this is the new kid on the block in terms of intracoronary imaging for post-transplant patients. And this has about a 10-fold greater spatial resolution compared to intravascular ultrasound, or IVUS. And you can see that this means that you can clearly see the layers of the vessel wall very, very clearly, the intima, the median, the adventitia. And what this enables you to do is to trace around these layers of the vessel wall. And if you do this in cross-section in let's say millimeter cross-sections across the length of the vessel, then we're able to obtain some sort of a semi-quantitative analysis of the disease. As well, OCT allows plaque characterization. So on the top left here, you see this classic appearance that I've shown now a couple of times of concentric intimal hyperplasia. But this is a study of transplant patients, and what the group found was that, in fact, there are patients who with plaque features that are very similar to what we see in atherosclerotic coronary artery disease, so with vulnerable plaque features and with more complex lesions. And this is important because it gives clues as to underlying mechanisms of disease in CAV and hence potential treatment targets. So I've shown you invasive coronary angiography as well as intracoronary imaging, and these are both anatomical assessment tools and limited to the epicardial vessels, so we cannot examine the microvasculature. Intracoronary hemodynamic evaluation provides a functional evaluation of the coronary tree, but also allows us to look at the microvasculature. So there are catheters available that have pressure and temperature sensors at the tip that allow simultaneous measurements of those parameters and the derivation of these three parameters. So fractional flow reserve, or FFR, which allows assessment of the epicardial vasculature, index of microcirculatory resistance, which is specific to the microvasculature, and then coronary flow reserve, which looks at blood flow in both the macro and micro vascular compartments. And this is a very nice study from the Stanford group looking at the value of these indices in the transplant population. And what they showed was that if you had an FFR that was reduced less than 0.9 in this example, very early post-transplant and hence reflecting donor-transmitted disease, or if you had evidence of microvascular dysfunction as evidenced by either elevated index of microcirculatory resistance at 12 months post-transplant, or that parameter increase in the first year of transplant, that these were all significant predictors of lower freedom from survival as well as retransplant. So integrating that information, we are currently conducting the ECAV study in collaboration with Toronto, where patients at early post-transplants at 3 and 12 months post-transplant are undergoing multimodality coronary evaluation using the tools that I've just discussed, so including OCT, intracoronary flow, and also PET, which I'll discuss a little bit later on. So far we have completed assessment for 51 patients at 3 months post-transplant, and follow-up assessment in that should be 20 patients. And this is the table showing the patient characteristics, which is typical for an early post-transplant cohort. What is alarming and striking to me is the burden of disease. So we see here that there is, so this is testing at 3 months post-transplant, that already that there are patients who have angiographic disease as well as IVUS evidence of intimal thickening, that is that they have donor-transmitted disease. Then furthermore, at 12 months post-transplant, that number increases. If you remember one of the original slides where I showed you that the prevalence of CAV is about 10% at 1 year, this is much higher at 33% already. And then progressive disease, which is the change in intimal thickening between 3 months and 12 months, there's also a significant proportion of patients with evidence of CAV in that early post-transplant period. Now, we've only got paired analyses for 20 patients, so I'm just going to show you this one slide for the results for the invasive coronary evaluation. On the top row is the OCT results, and you see that between 3 and 12 months post-transplant, there's a significant increase in intima area. There is no significant change in lumen area or vessel area, at least with the current patient numbers, to give us an idea as to what happens with the vessel in terms of remodeling. Also, when we look at invasive coronary flow, then there is a significant increase in the IMR, the index of microcirculatory resistance, meaning that there is a development of microvascular dysfunction. We and others have also observed this characteristic appearance on OCT of the plaque, what's described as layered fibrotic plaque. So if you look carefully, you can see that there are sort of variations in color, light and bright, in the actual plaque. And this is thought to be due to thrombus formation, platelet thrombi, and that this is postulated to be due to repeated injury to the intima and reparative attempts. And so this suggests that there is a central role for thrombosis, and that there may be a role for antiplatelet therapy. So I'm going to switch gears now and move to talk about non-invasive CAV evaluation, and focusing specifically on PET. And I've already spoke about some of the challenges that we face in terms of non-invasive imaging in CAV. And we and others have been interested in the use of PET myocardial blood flow quantification because in addition to detecting focal obstructive disease, it is able to assess both the micro and macro coronary vasculature, and therefore may be more able to detect the diffuse disease that we see in CAV. So in our PET-CAV study, we assessed the use of rubidium PET for evaluation of CAV. And in our original derivation cohort of 40 patients, we sought to determine optimal PET parameters for diagnosing CAV. We then went on to perform a validation study and looked at a separate 40-patient cohort. So in this particular study, angiography as well as IVUS were used as reference standards for CAV. So on angiography, the standard ISHLT definition that I flashed up earlier on, and on IVUS, we used a surrogate measure of CAV, so a maximal intimal thickness of 0.5 millimeters, which has been shown to be prognostic. So this is the patient characteristics of our two cohorts, and this was a fairly early post-transplant patient cohort. 3.2 years post-transplant was the median time for the derivation and 1 year for the validation. I'll just point out that the donor age, as expected, is young, so 35 in the derivation and 41 in the validation. There was a 44% prevalence of CAV in this population by angiography, and as expected, higher on IVUS at 78%, with no differences between the derivation and validation cohort. We looked at 3 flow parameters: corrected myocardial flow reserve on the top row, stress myocardial blood flow in the middle row, and coronary vascular resistance on the lower row. And what we observe is that for patients who have either angiographic or IVUS evidence of CAV, they had reduced myocardial flow reserve and stress flow and increased coronary vascular resistance. And there was no difference between this observation and the derivation cohort represented in the blue and the validation represented in the red. We then perform ROC curve analysis and showed that PET had good discriminative ability for CAV. On the top row, CAV was defined by IVUS, and on the bottom row, CAV was defined by angiography. You see that the curves are a little bit prettier for the IVUS-defined CAV, which is the more sensitive reference tool for CAV. And there was no difference between the derivation or the validation cohort represented by the blue and red curves, respectively. So on the, using the derivation cohort, we also determine optimal cut points on PET for CAV, and these turned out to be a corrected myocardial flow reserve of less than 2.9, a stress flow of less than 2.3, and a coronary vascular resistance of greater than 55. And when we combine analysis using these 3 parameters, we found that there was a high sensitivity of 83 to 88% for detecting CAV when 1 or more parameter was present, and a very high specificity of 88 to 90% when all 3 parameters were present. Hence, this is a useful algorithm for potentially identifying patients that should then proceed to invasive evaluation. We've also looked at PET in terms of informing on prognosis post-transplant. In this particular retrospective analysis, there were 121 patients who had 2 consecutive PETs performed within 6 years of transplant. You see that the average time for the first PET was at just over a year post-transplant, and just over 2.5 years for the second PET. And over a median follow-up of 3 years, 22% or 26 patients developed one of the primary composite outcome. You can see the breakdown there that the majority of the outcomes were related to new or progressive angiographic CAV. If we looked at the same 3 parameters that I showed you for the diagnostic study, so stress flow, corrected myocardial flow reserve, and coronary vascular resistance, the first row represents the first PET scan, and the second row represents the second PET scan. There was, for patients who experienced the composite outcome, there was a significant, they had a significantly reduced mean stress flow, as well as elevated coronary vascular resistance, but there was no difference in the other parameters examined. Then on Kaplan-Meier analysis, what we see is that the baseline PET for patients who had a value, the stress myocardial flow value that was below the median, in this case 2.1, as well as patients who had a persistently elevated coronary vascular resistance above the the upper tertile of 76, that these predicted adverse outcomes. So I spoke to you about the challenges in non-invasive imaging, and as such, we've also looked at the use of serum markers to assess CAV. This was a study in which we took a very highly selected transplant population, so 3 transplant population, one group with severe CAV, one group with mild to moderate angiographic CAV, and then a control group. And so it was a very small patient population of 31, and just to show you the demographics here, that they were reasonably well matched except for 2 parameters. As expected, the patients with severe CAV were much longer from transplant, as you wouldn't be able to find as many patients with severe CAV early post-transplant. And interestingly, they were more highly sensitized, although they did not have increased episodes of rejection requiring treatment. And in these patients, we performed the SOMA scan, which is able to look at over 1,000 protein markers, some of which may be important in CAV. And we found that there were 14 markers that were significantly different between the 3 groups. And when these were entered into pathway analysis, they were found to be important in 3 areas: apoptosis, inflammation, and platelet coagulation and activation, all pathways that have been described to be involved in CAV. And so these markers will now be tested in our ECAV cohort to see if we're able to validate. Of note, just the preliminary ROC curve analysis also showed that they all had fairly good discriminative ability to detect CAV. So where to from here? So we have concentrated research in CAV in 2 areas, early diagnosis and prognostication of patients post-transplant, and then also looking at some novel therapies. For diagnosis and prognostication, we have focused on PET imaging and physiology in the PET-CAV study, as well as biomarkers in the PICAV study, and this is culminated in the current ECAV study, where we are using multimodality coronary evaluation. At the same time, we also assessing the possible role of antiplatelet therapy, having we didn't have time to talk about this, but having looked preliminarily at aspirin resistance in the plate study, and hoping at some stage to conduct a randomized controlled study of antiplatelet therapy in this patient population, and also looking at the role of lipid lowering through a systematic review and retrospective analysis, and looking at the association between LDL levels and CAV, which interestingly has never been explored. And hopefully this information will inform on a subsequent clinical trial. So what I hope that we will eventually be able to do is to define pathophysiologic phenotypes of CAV, and that this will be able to be used for personalized screening as well as treatment. As an example, if we have a patient who is otherwise normal on these investigations, then perhaps this means that we could reduce the frequency of invasive surveillance. If we detect a fibrotic phenotype, then maybe this would identify patients that would be more likely to respond or benefit with treatment with the mammalian target of rapamycin inhibitors called sirolimus and everolimus, which we do not routinely use due to possible side effects. If we identify predominantly atherosclerotic type phenotype, then perhaps we should go down the treatment route for coronary artery disease with more aggressive antiplatelet therapy, lipid-lowering therapy. If we have a patient that has more of a microvascular dysfunction phenotype, then perhaps an ACE inhibitor or calcium channel blockers might be more useful. And that if we are able to define such pathophysiologic CAV phenotypes, then this would then lend support to a randomized controlled trial to investigate respective therapies. At the same time, with regards to PET, further work is needed in terms of diagnostic and prognostic parameters. Many groups have investigated the use of PET flow quantification like we have, but there is no universal accepted accepted cutoff that people are using for diagnosis or prognostication. So I'll end with a slide thanking the many and absolutely essential collaborators, both here and in Toronto, and I'm neither an imager nor an interventional cardiologist, and you can see that that is a huge component of the research, and also to acknowledge our research, our staff, and our funding support. Thank you.